against malaria. That's difficult to do, tenfold higher than a COVID vaccine might require. There are two licensed just in the last few months, and they're both based on the same antigen, the circumsporozoite protein, which coats the sporozoites that the the mosquito injects. There's a central repeat region here of 20 to 34 amino acid repeats, NAMP. All our protective antibodies likely target that. You need very high levels of them. And there are two formulations here. Back in some numbers are missing, the 1980s, RTSS was created by GSK, quite innovative at the time. They sell hepatitis B vaccine. They stuck the circumsporozoite protein, or at least part of it, onto that hep B base, if you like, to make a fusion protein. They could not express this on its own in the 1980s, had to put a vast excess of hepatitis B in, fourfold, so only 10% of this vaccine is actually malaria. And in 2010, with a better yeast and a stronger promoter, we were able to produce just the fusion protein. So why might that make a difference? Well, if you look at the cartoon derived from imaging of those particles, they're both the same size, about 20 nanometers. This is RTSS with little islands of malaria on the surface, but R21 is covered with CSP, and you cannot stain it with a hepatitis B monoclonal antibody. So that potentially should give you higher antibody titers, certainly higher avidity antibodies because of the greater density of antigen on the surface here. Some of you will know the papillomavirus vaccine, where you just need a single shot probably for life. The other difference you might spot on that slide is this needs 25 micrograms. We need 5 micrograms, which makes a big difference if you're trying to supply Africa or other continents with millions or hundreds of millions of doses. The adjuvants are relatively similar. We use matrix M, a simple adjuvant from Novavax. A complex AS01 adjuvant is needed by GSK. And this particle was made by Kath Collins, a graduate student in the lab in 2012, 25 years later. It got to phase 2 field efficacy testing in children in 2019 in Burkina Faso, not far from Ouagadougou. There's an excellent field site in Noro, very high seasonal transmission, run by Halados Tinto's group, and he devised a very simple trial with us, 3 groups of 150 children, 5 to 17 months of age, as in most malaria trials, differing in the intervention groups only in the dose of adjuvant, a 5 microgram dose of R21, and rabies as a control vaccine. A year later, we saw that in the controls, yes, there was a lot of malaria as expected. In the vaccinees, we had an unprecedented efficacy level of 77% over a year in the children who had the 50 microgram dose, somewhat lower in the 25 microgram dose, so we stuck with the higher dose of adjuvant. Is that higher than at the same site in the phase 3 trial of RTSS? Yes, it is. 77% is higher than 44%, but the numbers were fairly small in the RTSS trial. They had 11 different sites. But now, after 4 years of follow-up, and this is work led in Oxford by Maureen Datu, we've seen that over 4 years in Burkina Faso, yes, with seasonal transmission, we see 64% efficacy over 4 years, so it does drop a bit, but RTSS drops a lot more to 36%. So that was looking good, and because of that, Serum Institute of India, who are our commercial licensee manufacturing in Pune in India, decided to fund this phase 3 trial. We picked the best sites, our 5 principal investigators, 2 in East Africa and 3 in West Africa are shown here. 4,800 children enrolled now, an extended upper age limit of 36 months, not 17 months, we'll come back to that. 2-to-1 randomization, because you need usually 3,000 children dosed with data on them in a phase 3 trial for regulators to say that that looks reasonably safe. And a third of the subjects got a rabies control vaccine again. Cutting to the chase, dividing those sites into very seasonal and standard sites that are less seasonal, the efficacy